join the audience for a discussion about laws and incentives that the laws and incentives that hold us where we are or that we might be able to take advantage of for monitoring and assessment. So what stood out to you from that discussion? And if you have a comment, raise your hand, remember state name and affiliation, and someone with a mic will come and find you. Perrin, do you have a question for one of the panelists?
I do. You asked me about observations, and I observed that there's a disconnect, so that motivates a question. For those of you who won't, I'll stand for this. For those of you who weren't here yesterday, I'm Perrin Cobb from the University of Southern California in the City of Angels. And for my new friends and family here, my dear friend Boris, I was identified as the guy that he's trying to keep happy for the rest of the day, so I'll start off from that standpoint. I have the privilege with a number of people in this room of directing a network of networks for clinical research across the United States, funded by FDA, BARDA, the CDC, and also the NIH. And what I'd like to do is to give an example to the panel and ask for their input as we identify not recommendations, but solutions. We recognize that there's a healthy tension between the mandate to get information when we need it during a public health emergency, and there's an equally powerful mandate to protect the privacy of patients and the security of their families. So we get that tension. 5 years ago, the ASPR asked us to conduct a study on preparedness, a mock trial, if you will, where we were asked to enroll 150 patients across 10 institutions in a 24-hour period and get the data back to Dr. Lurie in the next 24 hours. We worked with representatives from Cerner and Epic to be able to address that question, and we learned very quickly that that was not doable, so we used a third-party solution, RedCap, to enter that information. We also tried to follow the rules, if you will, from IRBs. We had 12 IRBs that were participating nationally. One of the IRBs said it's ethical to collect information but no samples. Another IRB said it's ethical to collect samples but no information. And we had everything in between. And we had one IRB that said we won't even review this because we don't understand it. And I spent some time talking to the director of that IRB, trying to help them understand why this was so important to national preparedness. And ultimately, they didn't end up reviewing it. We did the study without them. That was our initial experience, and despite those challenges, we did a terrific job and delivered to Dr. Lurie what she needed. Fast forward 5 years, and I know this is not your intent, but this is the reality. So we're currently conducting national preparedness exercises for use cases in influenza and anthrax with case report forms that have no PHI, because we found it basically not doable working with IRBs for these exercises to be able to collect information that's protected. So we're just, in order to move forward with any sort of momentum, we're ignoring the PHI piece. We're also, and we talked about this yesterday, we've decided to some degree that working with our large vendors, Cerner and Epic, is not tenable at this point with available resources, so we're developing our own third-party solutions using FHIR standards to be able to extract data from Epic and Cerner without necessarily the support of those companies. So in short, we're developing workarounds to do exercises, but we all recognize that if there were an event, the task orders that we have are to develop protocols, robust protocols that allow us to be able to monitor and assess, in other words, do research on effectiveness and also safety, and we're stuck. So what I'd like to come up with, Boris, if I may, as a solution, is that we convene an advisory board for administrative preparedness to help inform those clinical trialists, those scientists who are working to be able to address this challenge as you motivated us, sir. Thank you, my dear friend, for the health of the nation. Thank you.
Good morning, Amy Groom with the Indian Health Service, and I just want to echo that theme around working with the EHR vendors, and I think this issue was raised yesterday about EHRs are made for billing and not so much for public health, and how do we get to the table? And I think Meaningful Use started to do some of that in ONC's work around interoperability, but it's kind of stopped there, and in light of the announcement that VA is now going with Cerner, that's a pretty huge system with a lot of data and a lot of people, and given the coverage that you already have in the private sector, and I know we have some tribes that go with Cerner, you know, how can we get policies in place that would help vendors be able to respond in an emergency situation to help us do that development and to push it out equally for everybody so that each person doesn't have to pay for their EHR instance to include that? Is there a way to get those vendors to the table so that we don't have to create these third-party workarounds to extract the data from the system? And I'd be curious what policies would help to motivate that on the EHR side.
I don't think you were looking at me, but no, I think it's a great question. I combined a couple of thoughts. One is that I think that it's not really a question of motivation or policy. I'm going to come back to some technical things. But for example, and many of you may know this, Neil Patterson, the CEO at Cerner several years ago, and he's been very public about this and not reaching any confidence, had a relative who died of sepsis, and a young woman, and he said, damn it, we're not going to, have it. It's a quote. I can get away with it. It's a quote, right? We're not going to let that happen again. And so Cerner, at its expense, went out and implemented sepsis surveillance algorithms and what we call power plans and a variety of other things, and made them available at every Cerner client across the world at no cost. And that was an example, I think, of where the mentality is there. So I think, though, the greater challenges, and I'm very glad that the folks at our great institution in the western part of the nation, in the middle part of the state, or wherever it is, I don't know my California geography, are looking at the open standards that health EHR systems are evolving toward, because exactly for that reason that things like FHIR are so important, because both the processes, so EHR vendors are subject to a whole variety of regulatory process steps. We can't just go and deploy software tomorrow. There's a whole series and a process that has to happen in order for us to do that, to keep our ISO 9000 certification, to keep our, a whole variety of things, make it very hard for us to be nimble. And so I'm very glad that you're taking advantage of the capabilities. So I think that's one way that we are trying to help, is by saying we need to be an open ecosystem that enables that kind of innovation and problem solving. So with Zika, for example, we work very hard to create tools and so on, make them available to our clients. But the third thing is that we still have tremendous variability, and this is true across every EHR vendor except Athena Health, who is a pure cloud-based systematic deployment. Every client is different in dramatic ways. And so we can push the stuff out there and it won't matter because of the differences in the way that clients have implemented the systems, in the way that things are used, in the way that data are labeled, and so on. That's something that hurts everybody. I think everybody recognizes that, but the genie's out of the bottle a little bit, and trying to put it back in is going to be a long, slow process to get to the point where you could, as a large international vendor, say, okay, go, here's this new data collection form, and have it work across the client base. So there's some technical hurdles there. So sort of my short summary would be, I think EHR vendors in general are very interested and passionate about trying to help public health move forward and enable our clients to be good participants in the ecosystem. There are some technical challenges to doing that, and I think that open standards like FHIR, the implementation of mappings to normalized terminologies like WOINC and so on, are all part of what we can and hopefully are doing today to make that more possible. So that's probably a longer-winded answer, but.
We have a question or comment here, and then we'll.
Scott Needle, American Academy of Pediatrics. Well, first of all, so I am a primary care pediatrician, so I want to say, I appreciate all the challenges that are involved with clinicians getting information from other clinicians, and at the same time that these are mostly, technical issues. These are not regulatory issues. It can be very frustrating trying to get information from a local emergency room. Even though under HIPAA it should be allowed, I still have to have the patient fill out a release form to get that information back on my very own patient there. There are these workarounds, and we're moving towards the full integration under platforms such as the Care Quality. The issue that I have as a clinician is more related to my communications with public health, and these relate more to regulatory and policy implementations on a state and local level. So I'll give you two instances. We've been talking about the use of the immunization registries. In particular, that this could be a very useful tool for tracking who's received certain medical countermeasures here. The problem is that most immunization registries are restricted to providers within that state. So if I have a patient who happened to be in New York at the time of an incident or received a medical countermeasure, I can't have access from Florida to that New York registry there. There are some records, some workarounds, and again, you didn't hear this from me. I'm not speaking on behalf of the AAP when I say this, but I can call up a colleague in New York and say, hey, can you get into that registry and just look up that patient data and fax that record to me? But this is the kind of workaround that we have. It would be nice if the registries themselves talk to each other. New York City and New York State registries don't even communicate there. But barring that, it would be nice if, as a medical provider, I could at least enroll in the New York registry and be able to download that information there. The other instance, and this is an example that just came up last week here in my state of Florida, the state surgeon general detailed that there were 7 babies that had been born in the state who had been neurologically affected by Zika. That's pretty much the only information that was released, and the state has been very steadfast against releasing any further details. Were they contracted locally? Were they travel related? In particular, the state will not release even the counties where these babies have been. And again, we've talked about the difficulty with balancing privacy and security versus the wanting to share clinical information. The problem is, as a clinical provider, it's a very asymmetric relationship, and it speaks to the fact that public health, if I can make a generalization, seems to not afford providers very much trust. We are not considered trusted partners. We are not allowed access to this information, and this is the kind of information that would actually help us provide care to our patients. It would help us communicate to our patients, better assess the risk, and if we want to enlist the clinical providers in a public health emergency, then I think there has to be a little bit more sharing of information, a little bit more trust, a little bit more back and forth, so that we can in turn help public health and help the community.
We have a handful of questions. We're going to go here, and then we'll go over here.
Yeah, I just wanted to piggyback on the sort of theme of individual decision-making, individuality that Mark raised in terms of pointing out that a lot of times people's EHR systems are very, the one Cerner system is one Cerner system. Well, what I have found is that one compliance officer's interpretation of HIPAA is one compliance officer's interpretation of HIPAA. I do not know why your policy people made you take that project to an IRB, because it sounds like a public health use to me, and it got treated as research in those institutions where the IRBs, that, in my view, it's not a HIPAA problem, it's an interpretation problem, a legal risk tolerance issue that each institution and organization applies in the way that they see fit. Our rules under HIPAA don't say you must disclose for public health, they say you can, which means if you want to layer on additional requirements associated with any particular initiative, you can do so, and I don't have the authority to just sort of crack down on over-interpretation of HIPAA. It's just, it's a set of permission slips, and it leaves a lot of flexibility to individual institutions and organizations to determine their own comfort level. And I'll also submit to you that that comfort level has maybe as much to do with competitive and business issues oftentimes as it does with privacy. The Zika issue and the types of data that people were willing to disclose being constrained, I'd be willing to bet money was more about impugning the localities where those cases arose and wondering whether there's a mosquito problem that women of childbearing age need to avoid that area versus wanting to protect the privacy of the babies or the mothers or the individual patients involved in those cases. You have to factor those issues into the equation because they play large roles in data sharing initiatives, much larger than I think people will often identify. They get masked as privacy more often than not, but they're often not about privacy at all.
Who has the mic over here?
So, following up on Perrin's and Devin's comments, we should be sure to distinguish between the situations in which we need to invent something new and when we just need to implement things that we already have. Devin was, before she joined OCR, was extremely helpful in socializing the FDA Sentinel system, which is a public health initiative doing things that look to all the world like research, if they haven't been involved in this. So one of the things we had to do was have one-on-one meetings and calls with the IRBs of the 20 systems that participate in Sentinel to explain to them why they had no jurisdiction. We had a letter from OHRP saying this is not research that is covered by the common rule. And we had a letter from FDA saying this is public health practice under the authority. And the response we all got was, okay, from the IRBs was, okay, let us take a look at it and we'll tell you that we think it's exempt. And what Devin helped us do was communicate, we are very glad to tell you what this program is and how it came to be classified as public health, but you don't actually have jurisdiction to declare it exempt. And it seems to me that's a piece of what we might recommend in terms of preparedness, because that's hard work to do while you're in the midst of saying, in the next 24 hours, can we do something? That was a period for 20 organizations. That was a period that stretched out over several weeks. But I think a broad-based program of saying, this is what public health authority means, this is what's allowed for sharing PHI, would go a long way to saying, sure enough, you can have that information. I'll add one more piece. We were involved in some of the assessment of the H1N1 vaccine, and in order to do that, the Assistant Secretary of Health convened calls with about 30 state immunization registries that were in the catchment area of Sentinel organizations, and basically made the direct plea, said, this is a situation in which we're asking you to suspend whatever other rules you have because this is an important public health need. So I think the combination of those kinds of active and ongoing messaging could be extremely important. We don't need new rules. We don't need anything else except to establish a common understanding.
We've talked a lot about the carrots and sticks that are getting in the way or helping us do work with electronic health data, but I'm curious about other types of data, about disaster operations, about clinical trials. What other carrots and sticks should we consider?
Chuck Cairns, University of Arizona. I'm going to first follow up with comments that Richard made and following up with Perrin's comments. I think that I was part of the National Academy panel on the learning health system and the military learning health system that was published last year. And this issue of HIPAA came up yet again. And thank you, Devin, for that discussion, because at that time, the HIPAA officer said health systems, unfortunately, are either overinterpreting HIPAA or using HIPAA as a reason not to exchange information. And this, I think, is really a critical issue. And so getting that kind of policy statement out, giving clarification and direction, as Richard pointed out, I think would be a very valuable component of this report. But I did want to go to incentives. So I do think that one of the areas for operations that was alluded to, but maybe not specifically cited, were all these other areas where patients and healthcare systems are integrating with populations daily. So the Banner Health System, as I said yesterday, has now reached out to Safeways. So we're not only having prescriptions and other things filled there, but frankly, they're getting blood drawn there. And so they become kind of peripheral practice site. Banner has also put in autonomous pharmacy dispensing machines, where if you're a Banner patient, there are these literal machines where you go and get your prescriptions filled. And so clearly the world's changing dramatically in terms of how patients within a healthcare system interact with the providers, interact with their places of care. So I'm sitting there thinking about medical countermeasures and thinking if we were to put those in Safeways or grocery stores, we already know places like CVS already have minute clinics. Now we have autonomous dispensing machines. I could imagine that we could not only distribute these things where people actually live and interact with systems, but we could put in place the kind of monitoring systems that would allow for data collection as just an inherent part of their care, as well as, of course, be able to directly connect with those people later for follow-up on effectiveness. And one more comment about Precision Medicine Initiative, because we were on the first floor of the academic centers for the All of Us program. All of those patients are doing consent, but it's a remarkable consent. It's a web-based consent, and it's pretty accessible. And we'll find out soon whether or not it's going to work. But in every single one of our focus groups, this is widely adopted or adoptable.
Comment here in the back, the very back.
So if the question is about, Sorry, I'm Jessica Corrales, I'm with Cadence Group. If the question is about carrots and sticks, the stick that I can suggest would be get your program managers to pester you. So public health being siloed is a drum that everybody at these sorts of things sort of dances to. So, you know, we all beat that drum, but the reason that we are all siloed is because of the human tendency to want to work with people who speak your language and think like you. So your lawyers want to work in legal departments, and they want to be managed by lawyers. Your data analysts want to work in data units, and they want to be managed by other data analysts because they all speak the same language. I was a data analyst embedded in a programmatic unit in Texas for 2 years, and it had the dual effect of making my job pretty frenetic, but actually causing me to stretch at the same time, because the program managers were always coming to the data team saying, we need this data, we need this analysis to do X thing. And data analysts are used to outputting numbers, and lawyers are used to writing legal opinions. If you force your people, your legal experts and your data experts and your program people in emergency preparedness to get together on a regular basis and plan, because the whole idea behind emergency preparedness is to be prepared before things happen. If you get them to meet regularly and plan and talk to each other, then they will learn to think like each other as well. So when your program people are faced with an emergency and they say, we need to do X, instead of coming up with an action plan that then is presented to the lawyers in its final form for them to put the brakes on it, or presented to your analysts in final form to design a data collection form for them to put the brakes on it, they start to think in other ways in advance before in bringing people in as they're making their preparations. And it shouldn't necessarily be an everyday professional way of life, because working in a data team in a programmatic unit got to be pretty hectic. But you should plan for these kinds of meetups and brainstorming sessions in advance. And to go up a level, what we found in Texas was that organizing peer-to-peer sessions was also very helpful. Like Ray mentioned up there, yes, the public health use within HIPAA is allowed for, and so if you actually get state legal departments to talk to each other. They can offer examples of past experiences, things that have happened, things to watch out for, and solutions that they implemented, and those kinds of peer-to-peer conversations tend to be a lot more open and fruitful than sort of a top-down approach.
So what are some other examples of leverage points, opportunities when we can influence these big P and little p conversations? We've talked a lot about having the right people at the table. What tables do we need to be at? No tables? Someone mentioned in the earlier conversation meaningful use and being engaged in conversations about the next iteration of that. Is that a table that we should be sitting at? Can someone say some more about that? Thank you.
So I think the comments about putting all the key people in a table and discuss about that, I think it's really great. And I have to say that the local people have been doing that, not just in Texas, because I have participated in many of them. I think the challenge is that it is really very difficult to get such a big group all together. And those meetings sometimes tend to be hours long. Everybody is very enthusiastic at the table and really wanted to do the work. And then they go back and try to connect to the pieces that they need to get, and they hit the rock, right? And then they got frustrated, and they try really hard, and after several weeks, and they may have given up, not because they give up on the issue, they simply do not know how to move forward. So I think it is difficult in terms of getting data, but I really appreciate the comments about the HIPAA. So I have to go for IRB almost every single week, and honestly, it is really funny because the IRB people will say, yes, this is exempted after we note everything. So you just have to go into the IRB application and submit it. And 3 months later, I still did not get exemption. So I think this is truly not, like, I think emergency response planning takes so much effort, and even just for the planning and testing those concepts, I think this is truly a key stumbling block, and I really appreciate what you mentioned. And I would think that maybe you need a dedicated person so that our IRB officer can talk to these people and be convinced, because sometimes even if they look at a paper, they simply will not get, like, they will not appreciate that still. So I do want to emphasize that, because I do think we got so much data, and I'm the one that got lots of data from many different places. And this is truly a difficult situation. Even though all the hospitals sign off or whatever, our IRB would not sign off either, right? So it is the same issue.
I'm curious if interpretation of HIPAA is an issue. Are there conversations that we could get into that would help change or correct interpretation issues and help that trickle down to the rest of the population?
Sure. I mean, you absolutely can. It's just, I think Rich's point is not that this is exempt research, because it's that it's not research, which means it doesn't belong in the IRB at all. Now, what I cannot control is whether an IRB within an institution is allowed to play a role in determining even when their authority applies. Like, that is an example of an individual organization or institution's decision, probably largely driven by risk tolerance, to give the IRB a bigger role than it would legally be required to have. Because frankly, when something is public health, again, with the Sentinel example, it was, OHRP has no jurisdiction, and the human subjects rules do not apply. HIPAA treats it as a public health exercise, and the research rules around seeking IRB approval for waiver of consent are not in play. But if an IRB within your institution is the one who gets to decide whether it's public health or research, then I'm struggling with how I can help.
But you can help socialize that.
Right, I can, and I'm happy to do so. Yeah.
Sorry, you have to introduce and identify yourself, please.
But this is an activity that has always looked exactly like research, and we don't do ourselves a service by calling it research. That's one of the things we had to do with Sentinel, was to say, these are assessments, they're not research, because the term research is so freighted with an activity that OHRP governs that there's a lot of background education work and maintenance to do to say, this is a separate category of activities. Because we got to yes with every organization in Sentinel, but it took a real investment to do that.
So we have literally like 60 seconds left. I'm going to ask you we have a couple of other people to make comments, so get it in fast.
Really quick. Chuck Cairns, University of Arizona. I'm just going to reflect. So we work with Perrin in the U.S. Critical Illness Injury Trials Group Preparedness Project. And so we've had a number of these issues come up where we've had to cite not only the language that we got from OHRP and from the FDA that this is not human subjects research, but then the IRB would say, well, we are the ones that interact with the healthcare system, and we're the ones that they lean on in order to be able, that appropriate use of their data is assured. And so I think that's why getting this piece will be really valuable, because then we can point that in this academy, forget whether it's a report or solutions or whatever it is, and we can say, this is the result of these discussions, and direct, this is public health, this is research, and these are our solutions for people who want to do public health emergencies and preparedness.
Comment, question here, and then we're going to wrap up.
So this is Jane Primer, FDA. I actually have a comment that is not going to go into whether or not we're determining whether MCM effectiveness is research or not research, but it's more towards the IRB issue and the reliance agreements. So in the case of an emergency, when we have local IRBs, we want local IRBs to defer to a centralized IRB to facilitate approval. How can we compel these local IRBs to defer to a central IRB, number one? And number two, is this part of the new common rule revision that any multi-centered study has to go through a central IRB as opposed to individual IRBs?
You have 30 seconds, and we have to end on time for this one.
Yeah. When funders and other vehicles put parameters around research studies that say you must use central IRB for X, that is going to probably drive more movement to central IRB. From a regulatory perspective, we have previously just said you can use one if you want, which gets you right back into the problem that we talked about. But again, this is public health. In my view, HIPAA, from a HIPAA standpoint, and the IRB would play no role in meeting HIPAA requirements with respect to the use of data for that purpose.
All right, great. So thank you, everyone, for the rich conversation. We're going to move to break, but before that, we passed out the lovely half sheets again. So write your name and affiliation on the half sheet, and then write down any lingering thoughts you have about carrots and sticks that we can use with relation to big data or electronic health data or clinical trials or response operations. Carrots and sticks that we should consider for doing better with MCM monitoring and assessment for effectiveness and safety. So carrots and sticks that we should consider. You can write your name and affiliation on the card, your notes, leave it on the document, the sticky wall outside the door to your right. We're going to have a break, and we're going to start promptly at 10:45 for the final keynote panel discussion. So please be back in the room at 10:45 to have the discussion. And please do leave your comments and thoughts on the wall. This is valuable, important information. We use it.